Welcome to Lecto. Today we are going to discuss polycythemia. It is actually a disease in which you will see the increase in the concentration of the hemoglobin. So it is actually a category of the myeloproliferative neoplasm, MPN. So let's see how it actually a type of the MPN, myeloproliferative neoplasm. So first of all, hemopoietic stem cell, which is the major cell in the formation of the different blood cells. So here you see that the hemopoietic stem cell divide into two, myeloid lineage and the lymphoid lineage. From the lymphoid lineage, B and T cell and the natural killer cell form. But from the myeloid, it divided into three categories. Myeloid. So first of all, you see that from the myeloid, you will see the formations of the platelets. So different steps are actually present, megakaryoblast, megakaryocytes. So ultimately it results in the formations of the platelets. Same here in the formations of the RBCs, different pro-myelo, pro-erythrocytes, erythroblast, different categories fall. So ultimately you will see the formations of the RBCs. And next is the myeloblast. It actually further divide into different categories. Myeloblast, you will see that it will result in the formations of the different cells like the Ben and the monocyte. So basophil, eosinophil and neutrophil. So basophil, eosinophil, neutrophil and the monocyte. From the myeloblast you will see these four types of the cell. So these are basically the cells which arise from the myeloid lineage. So if we see that the myeloproliferative neoplasm, it's mean the name indicate myelo, it's mean there is a defect in the myeloid lineage. In that situation you will see if you see there is a defect in the myeloid lineage, then it result in the increment in all the lineage, like the increase in the platelets, increase in the RBCs, increase in the myeloblast. And you see that if the platelets increase, then it is called essential thrombocythemia. RBCs, which we will discuss in this lecture, which is if the increase in the RBCs ultimately increase in the concentration of the hemoglobin, because the hemoglobin present in the RBCs. So concentration of the RBCs increase, then the ultimately hemoglobin concentration will also be increased. So in that situation, RBCs increase, which is called polycythemia. And if you see the myeloblast, basophil, eosinophil, neutrophil, these are basically the rare situation in which these lineage increase. But the most important is the platelets and the RBCs. So, hope so you got the point, the basic concept of the polycythemia vera, in which you will see the increase in the concentration of the hemoglobin. So next we will discuss the mechanism how RBCs increase in number. So we first of all discuss its genetically. So which pathway? First of all we will discuss the JAK2 mechanism. Here you see that this is a cell membrane. This is cell membrane, and you will see that there is a receptor. Here you see that this is a receptor. This is the receptor, and here you can also see that it has. So this receptor has two domains, extracellular and intracellular. So, and these receptors, which are basically the growth receptor, and these receptors carry the protein, which is shown by the red color, is actually the JAK2, genus associated kinase protein, attached to these receptors. So you see that this is a receptor having two domain, extracellular and intracellular, and in the intracellular domain you will see a protein which is the JAK2 protein. In that situation, if the growth factor, this is actually a growth receptor, so obviously growth hormone or growth factors will attach, you can say growth ligands will attach to it. So here you see that if there is a, this is a growth factor, this is a growth factor attached to growth receptor. So in that situation, growth factor, different growth factor like EPO, erythropoietin, which is actually a growth factor that increase the productions of the RBCs, and TPO, thrombopoietin, which is actually involved in the production of the platelets. So our main focus is the EPO because we are talking about the RBCs. So in that situation, if the EPO attached to the growth receptor, then what will happen? Here these are basically the close. When the growth factor attached to the receptor, here this one, then the intracellular domain, here normally two domains of the receptors are far apart from each other. But when the receptor, growth receptor bind, when the growth ligand EPO bind to the receptor, then their domain close each other. So in that situation, you will see the JAK2 will become phosphorylated. So in that situation, you will see the JAK protein become phosphorylated. And in that situation, it will transduce the signal inward. So here you see that this is a nucleus, and this pass the signal, this will pass to the signal to the STAT. STAT, STAT, signal transducer and activator transcription. This is actually a protein. This is actually a transcriptional factor, or you can say protein. It will move inward and activate the transcription, translational, and ultimately you will see that the formation of the different proteins which are actually involved in the division of the cell. So it means that you will see the whole process, ultimately the formation of the different proteins which are involved in the division of the cell. So it means that JAK2 mechanism is actually involved in the proliferation of the cell. But if the EPO attached, then it will involve in the proliferations of the RBCs. So JAK2, these growth receptors are present in the different, like if you see that the pro-erythroblast, these are basically the different precursors of the RBCs, and these precursors have different growth receptor, and these receptor bind the EPO, and it result in the formations of the or division of the different RBCs. So ultimately you will see the increase in the RBCs. So in that situation, it result in the polycythemia vera. So if we discuss the normal and the abnormal value, then here you can see that in normal, in the female, you will see the normal hemoglobin concentration, there is a range 115 to 155 gram per liter. This is the normal hemoglobin concentration in the female. But in the male, you will see the 135 to 175 gram per liter in the female. If we talk about the hematocrit, HCT, hematocrit, the normal value is 36 to 48. And in male, you will see the 40 to 52%. But if the concentration increase in the female above 155 gram per liter, or if the hematocrit concentration increase above 45%, then it result in the polycythemia. And same here in the male, above the 175 gram per liter and the 52% hematocrit increase, then if these value increase, then you will see that here you will see the polycythemia. So basically we diagnose polycythemia vera by the concentrations of the hemoglobin and the hematocrit. So next we will discuss the classifications of the polycythemia vera. We divide the polycythemia into two categories. So first of all, you will see that you will see the absolute polycythemia, and you will see that the apparent, or you can say pseudo polycythemia, apparent polycythemia. These are basically the same. different names of the same thing. Apparent polycythemia vera, pseudo polycythemia vera. So first of all, we will discuss the absolute polycythemia. So if we take a test tube and put the blood in this test tube and centrifuge this test tube, then we will see different things. So first of all, you will see that here is the RBCs will accumulate inside. RBCs settle down, and then you will see the next layer. You will see actually the 3 layers, and here is the last one. Here is the last one. If we take blood in a test tube and then centrifuge this blood, then we will see 3 different components. So here is the actually first component, which is the RBCs. RBCs settle down. Next component is the buffy coat. This is the buffy coat in which you will see the white blood cell and the platelets. You will see 2 different things. And last thing is the plasma. This is the plasma. So in that situation, in the absolute polycythemia, actual number of the RBCs increase. You will see that the RBCs number will increase, and you will see that the RBCs amount will increase. Normal hematocrit, normal you will see the percentage of the RBCs, you will see that the 45% RBCs. But in the absolute polycythemia, the 45% increment in the amount of the RBCs, you will see the absolute polycythemia. So this is the condition 1, in which actual RBCs increase. If we take the another example, apparent polycythemia, or you can say pseudo polycythemia, in which the RBCs amount is actually normal. In that situation, the hematocrit is normal, like 45%. This is the normal hematocrit. But the amount of the plasma is reduced. So here you will see that this is the buffy coat, and the amount of the plasma is reduced. So in that situation, RBC's amount is normal, but the plasma is reduced. Then they actually look like polycythemia. But in that situation, you will never see the reductions in the numbers of the RBCs. They look like, so we call apparent polycythemia or pseudo polycythemia, false polycythemia. So this is another condition, and this is mostly you will see in what situations that the blood plasma can reduce in our body. Yes, you will see that if you see the anasarca, which is actually the edema. In edema, the fluid from the blood will move into the interstitial space, and the amount of the plasma will reduce. And in several different situations, like if we use diuretics, if we use diuretic therapy, diuretics actually are the drugs that increase the volume of the urine. If the volume, lot of waters move from our body or excrete from our body, then automatically the plasma level will reduce, and it actually look like polycythemia. So these are basically the different conditions that look like the apparent polycythemia. So these are basically the difference. Absolute polycythemia, in which the RBCs concentration increase. But in the apparent, you will see the RBCs are basically the normal, but the plasma level will reduce. So next, absolute polycythemia is further categorized into 2. So you will see that first of all, you will see the primary polycythemia, and then you will see the secondary polycythemia. In that situation, in the primary, you will see that there is a defect in the bone marrow. In the primary polycythemia, you will see the defect in the bone marrow. But in the secondary polycythemia, you will see that the defect is external. So in that situation, in the secondary, defect is external. Let's suppose external means that there is an increase in the EPO, erythropoietin, which increase the production of the RBCs, because EPO is actually involved in the production or the proliferation of the RBCs. And another important point, if there is a defect in the bone marrow, and as we know that the three lineage derive from the myeloid, if there is a defect in the myeloid, then what will happen? It means that with the increment in the RBCs, then platelets and the other myeloid tri-lineage can also be affected. So in that situation, you will see the platelets count will be increased in the primary polycythemia, but in the secondary, you will see the platelets count is normal. Platelets count is normal, because in secondary we never see any abnormalities in the bone marrow. Only the RBC's lineage is affected by the erythropoietin. So this is actually the secondary polycythemia vera. So this is actually the basic difference between the primary and the secondary polycythemia. Next, we causes of the primary polycythemia vera. So two causes. First one is the congenital, and second one is the acquired. Congenital, which is actually present by birth. So congenital, we categorize congenital into EPO erythropoietin receptor mutation. If there is a mutation in the EPO receptor which are actually present in the RBC's precursor, then it result which is actually the congenital, which is present by birth. If we talk about the acquired, so if you see that the polycythemia vera, which is actually you will see that the JAK2 mutations, and two types of mutations can occur in the acquired form. You can also see the JAK2 mutation. It actually, in that situation, in the JAK2 mutation, then we will see that if the mutation occur in the JAK2, then without the EPO, these receptor will remain activated, and they transfuse the signal to the nucleus and proliferation of the RBCs. So in that situation, you will see in the JAK mutation, these receptors are defective, and without any ligand or the EPO, they transfuse signal and ultimately proliferations of the RBCs. So this is actually the acquired form, and you can also see the mutation in the exon 12. So these are basically the different mutation, and you will see in the polycythemia vera. So this is actually the polycythemia vera. Next, secondary polycythemia, in which you will see that these are basically the different mutations, as we have discussed that they affect the bone marrow. Next is the secondary polycythemia, in which we again categorize into two. So first one is the congenital, and second one is the acquired. So first one is the congenital. In congenital, you will see the high oxygen affinity to the hemoglobin, which creates the hypoxia. And when there is a reduce in the amount of the oxygen, then what will happen? Then EPO start producing, and ultimately RBC's concentration will increase. Next is the acquired. We divide acquired into four categories. So first one is the EPO mediated. So first one is EPO erythropoietin mediated. In that situation, in what situation EPO we can increase? First one is the smoking. In the smoking, if the EPO increase, due to smoking EPO increase, if EPO increase, then RBCs will also be increased. And high altitude. So keep remember that the hypoxia, this pathway. So hypoxia induces the EPO, and ultimately EPO produces the RBC's production. So this is the basic process. Hypoxia induce EPO ultimately increase in the RBCs. So this is the basic process which will happen in this way. Next is the local hypoxia. hypoxia. Next is local hypoxia, in which you will see the reduction in the supply of the oxygen at a particular site. You will see the renal artery stenosis, in which the narrowing of the artery of the renal or kidney, so which also cause the in polycythemia, because when there is a hypoxia, if you increase, then RBCs also increase. So this is actually, and you will see the end stage renal disease. Next is the pathological condition. In that situation, you will see that in lot of tumors secrete the EPO. This point is very much important. Lot of tumor like the hepatocellular carcinoma, renal cell cancer, and uterine leiomyoma. These are basically different tumors, and these different tumors secrete actually the EPO. And if the EPO increase, then the RBCs will also be increased. So in different tumors, you can also see the polycythemia. And last one is the drug-induced. Polycythemia. In the drug, like if we see that the EPO analog, which actually mimic the EPO, if we take such type of medicine or drugs, then it will also increase the polycythemia. So these are basically the different conditions, primary and the secondary. Next we will discuss the clinical feature, what features we see in the polycythemia. So first of all, we will see the headache. Headache in the polycythemia. Keep remember, different things happens in the polycythemia vera, like due to the increase in the RBCs, then you will see the hyperviscosity of the blood. Hyperviscosity of the blood. This is the condition 1. And next, you can also see the formation of the thrombosis. You can also see the hypervolemia. The volume of the blood will increase. So these are basically the different conditions. Due to these conditions, these clinical features will appear. So headache. Second one is the night sweating. So here is the night sweating in the polycythemia vera. Next, due to hyperviscosity, then you will see the night blur vision. Blur vision is actually the clinical features of the PV, polycythemia vera. And you can also see the pruritus, general pruritus. Pruritus can also be seen in the polycythemia, when these are actually more severe when we take a shower, or especially from the hot shower. So you will see the lot of itching on the skin. And gout. In the polycythemia vera, uric acid concentration is increased. Then due to the increase in the uric acid, then uric acid deposit in the metatarsophalangeal joint, and it causes the gout. Next, you can also see that the thrombosis, formations of the thrombus in the blood vessel, and you can also see the hemorrhage, which is the ruptures of the blood vessel. And in the polycythemia vera, this is actually the splenomegaly. Splenomegaly can also be seen in the polycythemia, in the advent of the spleen. And the most important is the plethoric appearance, in which you will see the redness. You will see the first of all, you can also see the retinal venous engorgement. So this is actually the condition, and you can also see the conjunctival suffocation. You will see the redness in the conjunctiva. So these are basically the plethoric appearance. Next, if we talk about the lab finding, then how can we diagnose the polycythemia from laboratory? So if we talk about the HB, hematocrit, and the RBCs, these are basically the high in the polycythemia. RBCs increase, hematocrit increase, and Due to the increase in the RBCs, then the hematocrit also increase and the hemoglobin due to increase in the RBCs will also be increased. Platelets increase. So keep in mind JAK2 mutation is very much important. In all these conditions, you will see the JAK2 mutation is common in these. But JAK2 mutation majority portion is actually happen in the polycythemia. So along with the polycythemia, you can also see the increase in the platelets count. And next is the bone marrow hypercellular. Bone marrow is hypercellular. So in that situation, all the three lineage will be affected, but the major is the polycythemia, which is the JAK2. In that situation, you will see the bone marrow will be hypercellular when we do trephine biopsy. In the trephine biopsy, we take the bone marrow and check it on the microscope. Then we see the hypercellular. Next is the serum EPO. EPO will be reduced in the blood. Why? Because EPO is actually involved in the RBCs production and utilized in the production of the RBCs. Then automatically the EPO production or level of the EPO in the blood will be reduced because EPO is actually utilizing in the production of the RBCs. Next, uric acid level, or you can say urate level will be high, which causes the gout in that situation. And you will see the JAK2 mutation, and you can see the exon 12 mutation. These are basically the different mutation. In that JAK2 mutation, automatically the growth receptor remains activated. In that situation, ultimately unlimited production of the RBCs happens. But normally, growth EPO attached to the receptor and activate the transduction. But if there is a JAK2 mutation, then receptor will automatically remain activated and produce the different proliferation of the RBCs unlimitedly. So this is actually the polycythemia vera. If you have any question, then you may ask in the comment section. Thank you.